Alrighty, week 2, opioids. So an analgesic is any medication that can relieve pain without causing loss of consciousness. So this is going to include things like opioids and even NSAIDs. An opioid is any drug, natural or synthetic, that has actions similar to those of morphine. So we have both things like morphine. We have like methadone, I think is one. Yeah, it is. Of course it is. Fentanyl, which is synthetic. Those are all opioids. An opiate applies only to the compounds present in the plant opium, whereas a narcotic means to make numb or to put a person into like a coma. So it has a very strong illegal connotation, so we don't want to use that. So we have the three main classes of opioid receptors. We have mu, delta, kappa. Mu is CNS, which means we're going to be, I think this is the primary receptor that we use. Delta, I don't think we ever touch that normally. And kappa spine. So it has some kind of CNS properties. This is a fancy little chart here that helps with all that stuff. Okay. Opioid intoxication. So normally, mostly mu, kappa. We can give it as a PO, an IM, IV, sub-Q, epidural, and intrathecal with, I think it was intrathecal that goes right in here, right beneath the dura mater. So you're going right beneath the dura mater. So morphine is, we're talking about morphine, of course. Morphine can be given all those ways. It is the least lipid soluble of any of these and doesn't cross the blood-brain barrier easily, which is really good. And only a small fraction of each of these doses reaches the site of analgesic action. Let's see. And so we're going to be using this for moderate to severe pain. And we can use it preoperatively and as an anxiolytic. It actually works really well when given with patients who are suffering from an MI, not just to help with their pain, but it helps to reduce their anxiety. It helps to open up their airways a little bit, giving them more oxygen potentially. It's wonderful as using an MI, but it can potentially reduce their blood pressure just a little bit. Adverse effects, the main one is going to be respiratory depression because of mu receptor stimulation. If given IV, that onset's going to be around 7 minutes, and that could persist for 4 to 5 hours. So, I mean, someone who overdoses on morphine on their own, and they go into respiratory depression and lasts that long, they may die. And it happens on a regular basis. There's an increased risk with infants and the elderly, as well as an increased risk with concurrent use of any other CNS suppressants, so any alcohol, barbiturates, benzodiazepines. The adverse effects are able to be listed by the acronym morphines. So meiosis is going to be this pinpoint pupil, and it is dramatically pinpoint. When you see it in real life, you're like, wow, okay, I know exactly what happened there. Orthostatic hypotension, respiratory depression, physical dependency, histamine release. I still don't really understand that one. Increased ICP, nausea, euphoria is one of the ones that makes them really feel a craving for it with dependency. And sedation. They also can have cough suppression, which is a good thing from the perspective of like codeine. Constipation and urinary retention. So we are going to be contraindicated in giving morphine if there is already any CNS or respiratory suppression or depression. We want to be very cautious about giving it in the elderly and with infants, as well as in pregnancy because of the increased risk of birth defects, and in patients with a limited respiratory reserve. So if they're already kind of like maybe COPD patients, they're kind of relying on whatever they have left in there, and if we give them this, suddenly then their pulmonary function drops by 10%, 20%. Now suddenly they can't breathe and they have to be have their ventilations taken over for them. This is going to interact with any CNS depressant, any anticholinergic medication due to the anticholinergic effects that morphine has. Hypotensive medications will potentiate each other and create an even stronger hypotensive reaction. Monoamine oxidase inhibitors. I know that MAOIs have the potential through tyramine of causing hypertension crisis. I don't know if that's something. I don't remember that. Yeah. Well, just know you want to be careful with morphine and MAOIs. I don't remember exactly why. Agonist-antagonist opioids will limit how much effect morphine can have on the body, and opioid antagonists will virtually completely limit any effect morphine can have on the body. So the toxicity or overdose of this, we have a classic triad of people or of symptoms. A person that has overdosed will likely be unconscious in a coma. They'll have very slow respirations, and you open up their pupils, they'll be completely unresponsive to your touch, and you'll notice a pinpoint pupil. Treatment for this is going to be primarily giving an opioid antagonist like naloxone, or as most people know it, Narcan, and giving ventilatory support. So, and we'll get to the specifics of naloxone at the end of this. Tolerance to morphine can lead to physical dependence. This means that we have an increased dose needed to obtain the same response, and the continuous presence of the drug can lead to adaptive cellular changes, especially towards receptors and how much medication they need to create the same response. So the tolerance itself develops towards analgesia, euphoria, sedation, and respiratory depression, which is good. But there is also no tolerance to pinpoint pupils, meiosis, or constipation. So those people are going to have a hard time pooping. And there's also cross-tolerance to other opioid agonists. So if you develop a strong tolerance for morphine, you're going to have also a strong tolerance towards fentanyl, for example. So abstinence syndrome, or withdrawal, will start with a yawning, rhinorrhea, which is that profuse secretions from the nose, and sweating. That'll then lead to violent sneezing, which is going to be really awesome with that rhinorrhea. Weakness, nausea, vomiting, diarrhea, abdominal cramps, bone pain, muscle spasms, kicking motions, insomnia. It's just all over going to suck. This starts about 10 hours after the last dose, though it depends on which medication or drug we're talking about, and can last 7 to 10 days if left untreated. It's very unpleasant, but not normally lethal, but it makes it very difficult for people to want to stay off the medication and go through withdrawals for the purpose of trying to get unhooked, because it's just such an unpleasant experience. So abuse then comes as when the drug is used in a way that is inconsistent with medical or social norms. Addiction is a behavior pattern based off of a feeling such a craving for the medication that despite physical, psychological, and social and/or financial harm, they continue to try to strive towards finding a source for that substance. Okay, so we have some strong opioid agonists. These are going to be similar to morphine in use and effects, and can be reversed with naloxone/Narcan. They're different from morphine. They each have their own level of potency, and they require some form of converting. And they may act different in different ways on receptors. So this is going to be a chart that would be utilized in determining how a certain medication responds or compares to morphine. And what we're always going to want to do is convert a medication dose, whatever it was. Like let's say we were taking hydrocodone and we wanted to switch to normeperidine. I have no idea why we'd want to do that, but so we would first, like say 60, we'd first convert to morphine, and then we would convert to meperidine. I've actually never used one of these, so I don't know exactly how it works, but there's a chart, and those who have to decide what the new dose is going to be, which I am assuming are probably going to be prescribing providers, will have to use something like this to ensure that people are staying on the right dose when switching from one medication to the next. So fentanyl is a very, very potent medication. It's 100 times the potency of morphine. It can be given parenterally, transdermally over the skin, transmucosally, so in a mucous membrane. And you'll see that a lot for very severe pain. Meperidine, or Demerol, has a short half-life. Unfortunately, it can interact adversely with several psych drugs and also can form a very toxic metabolite called normeperidine. So when normeperidine forms, it accumulates in the kidneys and can lead to tremors and seizures. And then methadone is another strong opioid. It's used to treat for pain and for opioid addiction. So there's a long duration of action, and there are no euphoric effects with methadone. And it can also block the euphoric effects of heroin and morphine to help with withdrawal symptoms. So say a person has an opioid addiction and they want to get off of that addiction, they're going to have to go through a withdrawal period regardless in order to come off of that addiction. And in doing so, taking methadone will help cease or reduce some of those withdrawal symptoms without providing a euphoric effect that would lead then to an addiction to methadone itself. And then eventually, as the symptoms diminish, they can be titrated off of methadone. Hydromorphone is a very common medication as well. Dilaudid is his normal name. May cause less nausea compared to other opioids, so it's a great consideration for someone in pain who's also experiencing nausea. And many of these preparations can include extended release, making it so that, like, let's say you have a post-operative patient who's just feeling super nauseous, but they're going to be in a lot of pain no matter what because of their surgery. Some Dilaudid could be wonderful. We also have moderate strong opioid agonists. These are going to be similar to morphine in use and effects and can also be reversed with naloxone. They're different from morphine in that they produce less anesthesia and less respiratory depression. And they also have a somewhat lower potential for abuse. So codeine, this is a common one used for pain and cough suppression with someone who's got a really nasty cold or maybe like an acute bronchitis or something. Oxycodone or OxyContin, this is one that has a higher level of abuse compared to other moderate strong opioid agonists. Though the analgesic actions are equivalent to codeine, and it's also a long-acting medication. Hydrocodone is commonly made as a combo in the form of Vicodin or Lortab. I don't remember which one has, I think Lortab's the one that comes with ibuprofen, and Vicodin's the one that comes in with acetaminophen. And these are the ones you're commonly going to get prescribed for at-home use after having a surgery. We also have opioid agonist antagonists, which will in this case be buprenorphine. This is a common medication that will be used for patients with opioid use disorders. And the way it works is that it is a partial agonist at mu, an antagonist at kappa receptors, which doesn't make much sense off the top of your head. But with that partial agonist at mu, it also has a very, very strong affinity for mu receptors. So, and this is where the may precipitate withdrawal in an opioid-dependent patient comes in. let's say you have a patient who is opioid dependent. They just had their last dose. It could have been oxy, could have been morphine, heroin, you name it. So they still have a lot of this, whatever substance it was, circulating in their body. If we give buprenorphine, in this case, to them, this buprenorphine, because it has such a high affinity for mu receptors, it's going to knock off whatever they had just taken and create a sudden withdrawal set of symptoms that will be kind of hard to treat because of the fact that it has a much higher affinity for these mu receptors. So what the recommendations are instead, so that we don't create this sudden and profound withdrawal symptoms set, is we let them come off of whatever last medication they had. So let's say they had oxy, had a bunch of it. They're not unconscious. They're not unstable or anything. Let them come off of it. Let them start to experience some of the withdrawal symptoms, and then we start to treat with buprenorphine those withdrawal symptoms. So pain assessments are important. These are going to be our fifth vital sign. And they're based on a patient's description, and it's subjective. Each person has their own scale, and that's okay. And we always want to do a pain scale before giving the drug, and then within 1 hour, around the hour, but not after the hour, after giving the medication. And then the dosing should be adjusted based on how they respond. Sometimes you may have to call the doctor and find out, hey, can we give more? PCA, patient-controlled analgesia. This is going to be a better form of pain control because the patient can have more consistency, not have to wait on the nurse having the time to come and give a medication, because they can just simply give it more often at lower doses and keep them right in that perfect therapeutic range for longer periods of time. Now moving on to opioid antagonists. These are going to block the effects of opioid agonists. These are, for example, this is a competitive opioid receptor antagonist. So it's not non-competitive. We aren't going to be at the point where you give naloxone, it completely blocks opioid receptors from being affected by opioids later on. They're going to go on there, they're going to compete for those receptor sites, and then eventually they're going to fall off. What's important about naloxone or Narcan given during a opioid overdose is that it has a very short half-life. So because of the fact that it's got a short half-life and shorter than most opioids, we have to remember to give more frequent, smaller doses of Narcan when someone's got a narcotic or opioid overdose. Otherwise, they may just go right back into respiratory depression, coma, etc. There was something else about this too. Oh, we also don't want to give too much because we could then have this profound transition from coma to very strong withdrawal symptoms, which is not good for our patients. So give just enough to get them out of their coma, to reverse some of that respiratory depression. There's still potentially, if they did this to have a high, then they may be very upset with you for ruining their high. So be aware of that. They could become somewhat combative. And then if they were talking about, simply a post-operative opioid effect patient, just remember that we have to keep on monitoring to make sure that they're coming out of the opioid effects. And then we also have methyl naltrexone, which is used to relieve constipation for patients who are on long-term opioids, most of which are going to be at their end of life. And it's a selective opioid receptor antagonist given subcutaneously.